cranial, ideal. Gross total resection, preserving the stalk, no permanent DI, no RADs, doing well 2 years post-op. Let's see case number 2, the old 86-year-old male, progressive visual decline over a year, almost blind, with no light perception on the right and legally blind on the left. Cystic solid, retrocellular and optic chiasm, and right optic nerve compression. And here's a small cystic extension into the third ventricle with normal pituitary function. On opening, we visualize the superior hypophyseal, and preserving them is essential to avoid further visual decline. We separate the tumor from the stalk and preserving the stalk. We dissect and resect the posterior capsule along the membrane of Lilliquist, revealing the basilar, the PCA, the SCA, the third nerve, and we can see the stalk and the superior hypophyseal. We dissect from the chiasm, carefully pulling it down by preserving, again, the superior hypophyseals. We go around with a micro dissector and we gently pulling it out. We then coagulate and cut the last attachment and remove this last piece of the tumor. And here the intraoperative decision is whether to leave the thin mantle of the cyst we saw on imaging on the floor of the third to preserve the third and to avoid high flow CSF leak since he's 86 years old, or chase it. We did the first, we opted for the first option, and we also preserved the stalk. So we struck the balance here for a near total resection with one tiny enhancing part at the floor of the third, no permanent DI with impressive visual improvement. He went for RADS. Let's see the third case, 41-year-old male, hydrocephalic symptomatology, no visual symptoms. The solid component, supra and retrocellular, but retrochiasmatic, hence no visual problems, and a very large ugly cyst in the third, occupying the third, pushing the hypothalamus, and he was hypopate already. And I want you to note the T2 edema in the hypothalamus, and this warns us to be cautious during dissection to prevent hypothalamic dysfunction. Transtuberculum and transcellular approach. This was a retroinfundibular cranial. I resected the solid component, but it's not safe to resect the cyst with such posterior extension or pulling it blindly in the context of this T2 edema. I decompressed it, and up to a safe point, we took also cyst wall. Small residual cyst lining, as you see in the third, and it went for RADS, otherwise no complications. And finally, the clivus and chordomas, some key decisions I would like to highlight: how to handle off midline areas like the Peters apex or disease behind the carotid, and some nuances when dissecting around the brainstem and basilar artery. 70-year-old male with double vision from left sixth nerve palsy, midclival chordoma, extends past the left petroclival synchrordosis behind the paraclival carotid. You see some carotid stenosis, likely compressing the sixth nerve in the interdural space, with some brainstem and basilar artery compression, but not extending deeper to the basilar. Of course, we need a transcrival approach, but is that enough, or do we need another transpterygoid? Probably yes. After the transpterygoid, we transect the median nerve, drill the canal, reach the foramen lacerum, aggressively drill below the canal, follow it to expose the lacerum carotid, and you can see we remove the middle clinoid, access the inferior paracellular carotid here. And remove the tumor from Peters apex, working behind the carotid, and relieve the sixth. At the intradural part, we dissect the tumor from the brainstem, expanding the dural cut inferiorly at the midline to avoid the sixth. And here we reveal the left sixth nerve, and we dissect carefully the tumor from the basilar artery, avoiding the perforators. And then with a 30-degree scope, what we do is we identify more superior or intradural remnant, and we cut and resect it. And here the last piece of the tumor hidden to the right of the basilar, which we remove. 4 days uncomplicated length of stay. sixth nerve resolved, the palsy resolved, and his immediate post-op MRI demonstrates no residual. And look at this last case. Chordoma causes significant brainstem compression and goes beyond and much deeper to the basilar artery level, diving into the brainstem. But the nuance here is to identify the basilar and the proximal part of the perforators, ICA and SCA early, and then carefully dissect the tumor away from the basilar, piecemeal working between the vessels. Here are the post-op images showing a near total resection with some residual at the lateral apex of the right posterior clinoid. And finally, stage-combined approaches could be considered, especially when you have lateral CPA component. I'm not going to go into details. We don't have time, but briefly, you can address the lateral CPA component with a retrosigmoid first, and this is what we did, and deal with a clival component and transclival within the next 3 weeks. So stage-combined approaches can be useful. I would like to thank you for your attention. And last, I'm just putting for a minute my brain connectivity neuro-oncology hat, which I equally love, to invite you to Toronto this September for NeuroConnect, our hands-on course in both white matter dissection with cadaveric brains and tractography, where we combine both methods to holistically explore and master the structural brain connectivity. And you can join leaders like Lorenzo Bello from Milan and others to be announced soon. You can scan the barcode for more information and come visit us in Toronto in September. And I'm sure Mario can back me up here. September is probably the best month to visit Toronto. Thank you very much.
Great. Thank you, Professor. That was an excellent talk. Now we'll move on, just in the interest of time, to our third speaker, Professor Philip Towski, who's going to talk to us about small cerebral aneurysms from the Brain Aneurysms Institute in Harvard. Thank you.
Yeah, thank you very much for having me. I appreciate the invitation, Mario. Good friend of mine. I really cherished the opportunity, and panelists and Kapil, thank you very much for doing this. I'm trying to share the screen. It doesn't let me here.
Okay, you click on the share button first.
Yeah, that's what I do, but it doesn't allow me to share my PowerPoint.
Really? So when you click on the share, nothing happens?
No, it comes up, but it only shows my Chrome tab and not my PowerPoints.
Okay. Well, I'll leave you to figure that one out.
I've never seen this before.
I can see you're not even trying to share. Click on the share button. Just click on that to see
Yeah.
that share. Click on that share button and we'll see what happens.
Do you see the share button?
Yeah. Yeah, I clicked on it, but it doesn't allow me to connect my presentation.
If you go directly to the presentation and open it up, and then come back and share. Open up your presentation on your computer.
Yeah, so it's
and then check the share button.
It should give you the option of selecting multiple screens, so you pick with the one with the presentation.
Yeah, it doesn't.
Doesn't?
Let me log out and log in again.
That's
Okay.
fine. That's fine. In the meantime, I'll go with some questions for the other faculty speakers. Okay, Phil. Take your time. I would like to comment first with on the talk from Professor Plaha. And basically, I think the take-home messages were very, very clear. nowadays we do not select our surgical strategies anymore according to information from our textbooks. We do not go through book chapters regarding how we manage lesion in the occipital pole or parietal pole or temporal pole. We select the information that we possess depending on the specific needs of patient. We have a number of tools that are very key in terms of surgical aid for us, and I believe that the tailored surgical approach will be more and more our day-to-day practice in the near future. The other comment that I have regarding the presentation is obviously all the information that Professor Pla has collected through Future GB, extremely relevant. They are informing our practice. And I'm pretty sure that there are new trials coming on soon. Is that correct, Puneet? Can you please share some news about that?
Yeah, no, thank you, Mario, and thank for the opportunity again. I think Future GB will answer that question. It'll give us class 1 evidence whether DTI and ultrasound in addition to 5LA makes a difference to patient quality of life. And then we finished the recruitment multi-center in the UK, and then now we've got NHR funding for a recurrent GB, which is the new trial will open next year. And that is to answer another question. Again, using all this technology, do you make a difference when the tumor sadly comes back? And does second time surgery make a difference to patients' quality of life and improvement? I think that's the evidence lacking significantly in our literature. And again,
Yes.
this multi-center trial will answer that as well. So yes, so I think over the next 5 years, I hope we'll get more information on class 1 evidence for some of this technology that we are now using. And you're very right. We're all looking towards personalized surgical approach for each case, individualized, rather than set what your textbook say that you put it there. Yeah, thank you.
Yeah, yes.
Okay,
And,
Phil is back. Phil, you want to try again?
Yes.
Phil, are you there?
I think, Phil, as soon as you keep on trying to share your presentation, in the meantime, I'll carry on with some more questions so we do not have any downtime. Ari, of course, I share beautiful memories of our time in Toronto. Excellent neurosurgical department. And I'm very pleased that you are bringing forward the work that I had seen done by various master surgeons there, obviously including the current Mayo Neurosurgical Department chair, Professor Zadek, and our Italian pride as well. Who unfortunately passed away a few years ago. Can you tell us a little bit more of how you are passing this knowledge to your trainees, and what is your experience now that you have moved to Athens, and bringing all these excellent surgical quality to your home country?
Yes, thanks, Mario. I think it's a meaningful homecoming for me. It was a significant decision to move back to Greece, to Athens, to take on this new academic role. I really enjoyed so far. It's quite early. First of all, I think as you start a practice like this, and I do a combined practice of skull base and oncology. First of all, you have to build the numbers, build the volume, and countries like Greece, they don't have this highly regulated practice like UK or Canada has. So you have to put an extra effort to build first the volumes needed for good quality training. So I'm at this stage now. And later on, what I plan to do is potentially have a fellowship established. Yes. But for our residents now, I think the key is having these two big categories of approaches for skull base is to pick the best. And when endoscopic approaches came along, everybody was talking about endoscopic versus open, and now the field has moved forward and everybody is talking about endoscopic and open approaches together for achieving the best possible results. I think endoscopic approaches and endoscopic skill set requires a number of cases for residents to set up realistic expectations. What I say is that, you know, you have to slowly build your confidence, probably starting with some pituitary cases, holding the camera, doing some initial steps of the procedure, like, you know, middle turbinectomies when needed, or sphenoidotomies, and gradually build your confidence and experience to go deeper. Yeah, I think that's one good suggestion for young trainees.
And particularly because this, as the the title of this initiative says, we are open to collaboration with neurosurgeons from the entire planet. Which type of advices would you have? I remember in Toronto, it was really an international fellowship. We had young surgeons coming from all over the world, very different backgrounds, and you know, melting very well with the local community, and then returning to their own countries to set up new practices. And I think our goal as alumni is exactly to replicate this type of approach. This is what I'm trying to do here in Oxford, and I'm pretty sure that will be your agenda in Athens too. What do you think would be the advice that you could give to young neurosurgeons from all over the world? They are just starting their residency or completing it, what they should look forward in order to make the big steps and become independent surgeons and attending surgeons?
I think that you know, we are now in an era where subspecialization has to be considered early on by surgeons in their training. Of course, they have to be safe in all general neurosurgery procedures. We don't have to. We shouldn't forget that every trainee, senior trainee, and young you know, consultant attending should be proficient and safe in all general neurosurgery procedures. But we are in an era of subspecialization. I don't think that any surgeon can provide perfect care in all specialties, subspecialties, and they have to realize that early, engage with mentors in the specific field, trying to gain some initial experience of their subspecialty during residency, so then they maximize their chances of getting significant experience during their fellowships, right? Because especially for you know, endoscopic, skull base, or other very subspecialized you know, fields, if you go with zero experience, probably you don't gain much from your fellowship. So this is what I would recommend to them: just gain some initial experience, and then you can learn the field during your fellowship and during the very constructive early consultant attending years. These are precious.
I agree definitely on that, because I remember when I arrived there, effectively, you know, my mentor was Professor Fellings. I was allowed to basically serve as a step up attending and cover all these critical throughout the academic years I served in Toronto, and was a very significant experience. But obviously you cannot be that green. You need to be already experienced, be able to deal with the calls, being able to make decision and take patient to the OR. So I agree with you. It's important to start thinking early about the opportunity of fellowship, particularly international fellowship, but you need to be well prepared and know your bread and butter before you go there. On this, I would like to bring in Phil. Phil is the co-director of the Brain Aneurysm Center at Harvard. Phil, I would suggest, in the interest of time, I would prefer to give you one entire slot, perhaps next month, for your presentation, and perhaps we can do surgical and endovascular talk. I can pair you with another very good colleague of mine from Chicago, and we can do at the time that suits best the American continent. What I would like. It would be always a pleasure to have you, my friend. What I would like you to chip in here is obviously having reached this position in the US and coming from our good old European continent. Can you please share your experience? Tell us what would be your recommendation for young neurosurgeons here or anywhere else in the world?
Yeah, thank you, Mario. I apologize again for technical difficulties. I think it was a Zoom update issue, but I missed part of the discussion. I like what you just said, Mario. I first of all, I think the opportunities in North America are exceptional, just in terms of volume, in terms of infrastructure, in terms of ability to write and publish and develop yourself. I very much agree with what you just said. These fellowships are fantastic. There's a deep desire to teach. I think that's very much of part of the British culture. And I think that the Americans took over from the British, but a real interest and joy and pleasure, dedication to teaching. But it only works when you come, like you say, you need to come well prepared. These fellowships, they're really post-residency fellowships. So it's not good if you need to get the basics or if your anatomy is not in place. The other thing that you pointed out that is very true is that unfortunately you need to sort of apply early on. So we have an open slash endovascular, so a combined fellowship. And we're interviewing right now for 2029, which is even for us a little crazy because it's 4 years out. So basically, we're interviewing residents who are in their second or third year of residency, which is too early to make a decision, I feel, which subspecialty you want to go to. But it's just the reality of it. A big hurdle during my time was to do the USMLE, because there were not really good teaching books. Nowadays, there's a lot of online question banks that you can subscribe to and do it. And so it's become, it's a hassle. You need to dedicate yourself to the USMLE. But I would recommend to anyone, especially who's interested in an academic career, take the USMLEs, do the online questions bank, the USMLE World, and make sure, like you said, that you're really well versed in the basics so that you can take that next step for the post-residency fellowship.
Yes, and what I would say is that to me, those the years of fellowship have been possibly the best years of my life, and I saw them rather than just a professional opportunity. Those were life experience to me. You usually live in big cities, world-renowned neurosurgical centers. Really, it opens up your horizons. I think we are almost on time. Is that correct, John?
Yes, very good. You got it under the wire. And we have to leave now. I apologize for being so in a hurry, but Mustafa Baskaya is lecturing in a half hour, so I got to move.
That's the nature of our business. And please be reassured that we will have Professor Toski next month. We are going to work on a date ready at the end of this webinar, and I'll make sure we have both endovascular and open vascular talks. Perhaps we'll limit only to 2 talks next time, so we'll give an extended time for presentation, and I believe there is a lot of value in this talk, because it brings our attendees closer to world-class surgeons like the ones we had today. I want to thank Puneet, Phil, and Ari. You are like brothers to me. Thank you very much for accepting my invitation. I'll see you next time. Thank you.
Thank you,
Mario.
Aristotle,
Thank
Puneet, and everyone
Thank
else,
you, Mario.
Mario, of course. And we'll see you next